Would you like to click or do you want me to click?
It doesn't matter.
Boy, it's better if she does, I learned.
Hi, Heather and Sarah Sanson from Camden Family Health is here too.
Great. Awesome, thank you.
All right, so we're going to be talking today about the benefits and challenges of group therapy. The objectives are on the next slide. Just somewhat of an agenda. The group therapy actually started in the United States back in 1906 by a doctor who was treating patients with tuberculosis in their homes and in various community locations that could not afford to go in institutions. Dr. J.H. Pratt from Boston decided that he needed to help patients who are not able to get the money or the funds available to get treatment, but also found that there was some emotional side effects being treated as well while he was seeing his patients. In 1956, he determined that he was operating a home sanatorium treatment for consumptives rather, as well as group psychotherapy. We take a look at groups in human nature. The lives of individuals are shaped for better or worse by their experiences in groups. Everybody in this room at one point in time has had really positive and maybe not so positive groups. I was in the Boy Scouts of America, very positive. Sports groups my parents put me in as a child, not so positive. We are born into groups throughout life. We join groups, they influence us. Our family, our religious, our social and cultural groups constantly shape our behavior, self-image, and both physical and mental health. We all know of groups that have been very positive in the news, and we also know of groups that have been very negative in the news, but they still have members that believe in what their solution is. We like groups because they can support individual members in times of pain and trouble, and they can help people grow in ways that are healthy and creative. Groups can also support deviant behavior or influence an individual to act in a way that are unhealthy or destructive. In juvenile corrections and adult corrections, we often hear about parents sending their kids to placement and children learning more bad things in placement than sometimes good things. Or we hear about adults going to prison and hearing about learning how new ways to commit crimes and getting away with it. So there are some negative sides, but more positive than negative most of the time. We want our groups to be a compelling source of persuasion, stabilization, and support. Often for many of our folks in treatment, the groups might be the only kind of social contact they have for the week. Or maybe the only healthy social contact they have for the week. We tend to have folks that come into groups in crisis. We've had several in some of our clinics. We have a regular girl that cries almost every week about her children and cases that she's dealing with. And she gets support by her peers who reassure her that she's doing everything she should be doing. So group work is not always rainbows and unicorns. There's often crises and challenges as well. But the idea is that we can comfort and guide people who are otherwise unhappy or lost. So if you have well-trained group leaders, the potential to create change is there. We can foster healthy attachments, set boundaries, model behaviors that are appropriate, encourage positive peer reinforcement, often acting as a forum for questions and information and discussion, allowing people to have self-expression and ultimately to teach new skills. Again, when we look at individual members in times of pain and trouble, we can often help them grow in ways that are healthy and creative. So if you're looking at somebody who has used substances to deal with their pain, their stress, things like that for so many years, we can have them come to the group, talk about ways that are more healthy and not substance use related. And really, group therapy and addiction treatment are natural allies. So group therapy seems to work well for addiction treatment based on the idea of affiliation. that folks feel like they belong somewhere. A lot of folks over my years have told me they feel very lost, they feel very alone, which is often sometimes why they start using. But even after they start using, sometimes they still feel that way. And especially if they're in recovery, trying to reach things. Confrontation, we can often confront patients about their use, hold them accountable for their actions, and they can be confronted by their other peers as well, which is just as beneficial as a provider doing, and if not more. We offer supports that they need, referrals to other services, gratification when they're achieving the goals that they have set for themselves, and identification of other problems or situations that may have arose throughout their treatment. So when we look at group psychotherapy versus self-help groups, the first board there are all components of what a group psychotherapy looks like. A mental health professional of some type, members are selected, groups are limited in size, often some type of payment is collected, enforcement of rules of confidentiality, and they're based on individual kind of client participation. Compared to self-help groups, the next slide, that is often not run by a mental health professional, do not have the same limitation in sizes. Usually no money is exchanged, and rules are kind of created based on past history or by members, or when you're looking at 12-step groups, whatever kind of the 12-step communities kind of create the rules from themselves, either from national office or what the local chapters have created. And clients are able to remain quiet. Obviously in group psychotherapy, if we have folks that are quiet, that's okay as well. But we hope that they eventually are going to start talking. When we look at self-help groups, somebody may just go to a self-help group and listen for a really long time and not share anything at all. There are several different types of groups. When we look at groups, there's a psychoeducational group. This is the group that we use a lot, or that I use a lot, to teach about substance use, abuse, and addiction. We look a lot about brain disease. What is addiction? How did I become addicted? What does it mean to have a disease and addiction? Skills development, where we help them to hone the skills necessary to break the cycle. So this is learning about the people, places, and things, for example, that are causing them to relapse, or the people, places, and things that are helping them to stay sober. The rearranging of the cognitive behavioral groups is where we help them identify their emotions, their thoughts, to their behaviors. So when they're dealing with depression and anxiety, learning how to use coping skills instead of using the substances they were previously using. Support groups, the idea again of members being able to hold each other accountable and debunk each other's excuses and create supportive, constructive change. And then interpersonal groups enabling clients to recreate their past and their here and now. So the idea of playing the tape backwards or playing the tape forward, re-examining behaviors, re-examining relapses, exploring things like that so they can learn from them. Advantages and rewards. Obviously, we provide positive peer support and pressure to abstain from substances as a group. There is something to be said about having to come into a group of people and have to admit that you are using and that you relapsed. Often people will tell me they feel much better after they tell the doctor they have relapsed, but they also feel somewhat of a pressure to avoid having to do that by staying sober. Reduce the sense of isolation that most people have. For example, I run a thought disorder clinics, social skills groups, and for most of my thoughts patients, the only socialization they have that week is coming to that group, and they've been together for 10 plus years, and it's just really part of their lives. And when we look at monthly clinics are often the same way. People with multiple years of sobriety, connecting with each other once a month, expecting to see each other, expecting each other to do well. Again, witnessing substances, witnessing the recovery of others and the challenges of others. I think both are beneficial. Learning how to cope with their substance abuse and to see how others deal with their similar problems. Providing useful information to clients who are new to recovery. One of the things that I often do when people come into clinic is have everybody go over some of the rules. What's one of the rules that you struggle with in groups that this new guy or new girl kind of knows what's going on? If you're struggling with it, most likely they're going to struggle with it at some time as well. Values and abilities. I think a lot of times group can confirm that you are valued, even though you have an addiction history and you are in recovery. You are a valued member of society and you have abilities to do things more than just use drugs and alcohol. And for some, it's very family-like. I have a lot of females that will exchange phone numbers with each other in group, communicate kind of outside of group. And of course, we use it to encourage and coach, support, and reinforce as members take on difficulty or anxiety-provoking tasks, such as dealing with families, holiday times, things like that. Learn and relearn social skills, effectively confront individual members about substance abuse and other harmful behaviors, and allow a single treatment professional to help a number of clients at the same time. I believe I can do a lot of work in a 1-hour session with patient, but I can do a lot more work in a 1-hour session with 12 patients, spreading the same kind of information across everybody instead of just one-on-one. Groups can add needed structure and discipline to the lives of people with substance use disorders. You know, that's why the COPE model or the West Virginia model has the positives and the negatives, the consequences for the negative behaviors, so that we're holding people accountable for their actions. And I think a lot of it is instills a hope of, if he can make it, so can I. Ask a lot of people in individual therapy when I have somebody graduate from clinic, hey, so-and-so just got 90 days. What's that do for you? You know, that excites me. I can do it. I'm right behind him. If he can do it, I can do it. And we often use groups to support and provide encouragement to one another outside of the group setting. A couple other rewards or benefits of group or data collection and research opportunities. We have tons of those here at WVU Medicine. Often we're collecting data, giving research opportunities, collaborations with other agencies, departments, and divisions. We had the Hep C treatment grant run for a while up here, and that helped a lot of people be able to get sober or cured from Hep C. We just started doing Hep A vaccinations in clinics within the last 2 weeks, I think, and that's going well. But it's also used to treat comorbidities that often accompany substance use disorders. I feel like a lot of therapists or group leaders feel like they can only talk about drug and alcohol, but really we should be talking about drug and alcohol and the comorbidities that are often causing them to kind of use, especially the guilt and shame piece. There's lots of guilt and lots of shame, and explaining the difference between both of those and kind of how those vary depending on your recovery. Group leadership is important. Groups must be led by trained leaders that are designated to promote recovery from substance abuse. Often here, when we have a new therapist come in, they will observe many of our groups before we have them take on their own group. For all of us that teach graduate students, we often have them run our groups, but under direct supervision, so they can learn how to facilitate groups appropriately. But it's really important that you guys have a strong leadership in the groups that are being run. So that brings us to our challenges section, which is a little bit smaller, and that's good. So poor leadership, obviously many groups led by untrained or poorly trained leaders have not fulfilled their potential and may have negative effects on the client's recovery. If you have a group leader who doesn't care or has a bad attitude or goes into group not caring, members will pick up on that, and that can change their own attitude. I've had bad days, and I've been caught up on my group members several times on my bad days saying, I just need to suck it up and get it together because my life is not as bad as theirs. But it's the truth. They help us so much as we help them. Inadequate educational materials, not having the resources that you need, the knowledge and the resources that you need to kind of facilitate group, not having the basics that you want. And then obviously additional training for therapists that want to do more advanced groups such as DBT or some of the other things. Inadequate therapy models, so using individual therapy models more for group settings. Confidentiality, we face this a lot in group. And we have different policies on that here about group members not responding, not respecting the confidentiality of other group members. So I recently had a female patient coming to me the other day and say a male patient talked about her at one of the 12-step meetings about stuff that was said in group. So we handled that, and it was not, we ended up transferring that patient actually out of her group into another group because it just wasn't safe to keep them in that group anymore. Insurance companies, folks that I've seen with commercial insurance often fear retaliation or rejection of insurance claims or life insurance if they have some of these disorders kind of further down the road concerns. And of course, you got the big one with, making reports and referrals to CPS, probation and parole officers for folks that are on mandatory treatment and reports. Obviously, we do a lot of obtaining releases here, but we also utilize kind of a treatment confirmation letter. It's short, sweet, and to the point, confirms the patient's in treatment. This is how long they've been in treatment, how many sessions they've attended. This is their drug screen results, sign, fax, and we're done with it. We don't talk a whole lot about what's said in therapy, either individual or in group. And educational learning challenges, clients not all being on the same educational level. Even after 11 years, I've walked into a group sometime expecting people to do a worksheet, being ignorant of the fact that somebody can't read in group. And then I have to kind of rethink my strategy, or somebody forgot their glasses that day and can't see. And then using big words or technical terms. I think all of our docs here on staff are pretty good about talking on everyday level, but that's something to keep in mind as well. And logistic concerns, not having a location to do groups, not having group room availability or small group rooms, patients not having transportation services to groups, and then recently for us, group room temperatures, not having appropriate air conditioning, and just how miserable that makes people and how much of a challenge it is to keep in mind. A whole bunch of scholarly resources there, and then my contact information at the end if anybody has any questions, comments. If it's good, I'll take them. If it's bad, I'll give you Douglas's information. So if there's any questions, we'll take them now. Pretty straightforward.
Excellent. Thank you so much, Lawrence.
Lawrence, can you say something about tough situations in group therapy, like angry patients or scapegoating or coupling, some of those things?
Yeah, so I think one of the biggest challenges that we find is when we have to discipline a patient in med group. So we have to send a patient back to bi-weekly group, or we have to make them check in daily. They often come to group very angry about that, and they often don't care, and they want to leave, and they can't. So often what I tell them is that I understand you're angry and you're allowed to be upset, and that's fine. You don't have to participate, but I can't have you disrupt my group for everybody else at the same time. So, we give them their space and allow them their time, but ask them to respect everybody else at the same time. I certainly think we do, we often try to take judgment out of groups too, everybody, and there's a lot of judgment in the addiction community, and there's a lot of judgment even in groups sometimes about people. So that's really just about creating a safe space for everybody kind of from the beginning, and really identifying those triggers and those trouble folks and addressing it individually or as a group sometimes to deal with them.
I just want to add something to that really quick. Lawrence used the word discipline. We actually do not discipline our patients. We just increase their level of care as we see fit. So if a patient's dishonest with us and we move them back to a weekly group or something like that, we're not actually disciplining them. We are just feel that their level of care needs increase.
Yeah. One thing I've encountered with this population more so than others is that sometimes I'm finding out in a group therapy session that another patient has overdosed or passed away. Maybe a patient that was previously in that group or was in that group currently, or patients just, for being a part of COAT for so long, folks knew. And that's happened, I don't know how many occasions. So I'm finding that out in group, I'm having to figure out how do I sort of honor my grief at the same time, and then make sure I'm doing the role as the lead of that group to help out as much as possible for the other folks in that group doing their own grieving. So that's, I think, one of the real importance of the treatment team, and for all clinicians to be working on in their own supervision of sort of making sure they're aware of what their emotional boundaries are as a group therapist.
And I think the opposite of that, of finding out ahead of time,
Mhm.
before you go to group, and then try to decide what your patients should know and what they should not know to still protect confidentiality, but also respect their wishes to know what happened to one of their group members they were really close to. And
Yeah.
we battle that a lot, I think, in treatment team. And I don't think we really have a black and white answer on that. It's certainly case by case basis. So.
Yeah.
Do you guys have any questions you want to throw out?
Great presentation, Lawrence.